All right, well, thank you and welcome everyone. You can go on to the next slide. So I'm really glad that this presentation is divided into two parts because as you'll see, if you listen to both presentations, there really are sort of two different aspects to making a diagnosis and managing pregnancies complicated by fetal growth restriction. And I like to sort of draw to my attention for my students and residents that this really is sort of a ticking time bomb in a way, where this fetus that's sort of hidden from our visualization really has the potential to get into a great deal of trouble if we're not careful, and sometimes, quite honestly, even if we're extremely diligent, sometimes the outcomes are not as favorable as we would wish. Next slide. So fetal growth restriction is actually the second leading contributor to the perinatal mortality rate, second only to prematurity. The mortality rate is increased 6 to 10-fold, and the background rate of 8 per thousand is increased to 120 per thousand for all growth restricted fetuses, or 80 in 1,000 if we exclude anomalies. Next slide. 40% of stillbirths are significant in that they have some element of fetal growth restriction. That's 53% of preterm stillbirths and even 26% of term stillbirths. Intrapartum asphyxia has been reported in up to 50% of growth restricted fetuses, and greater than 60% will have fetal heart rate tracing abnormalities, which indicate hypoxia and or fetal acidosis. Next slide. This graphic sort of illustrates an important point, that as the fetal size gets smaller and smaller, the risk increases geometrically. And so although you'll see we define growth restriction as estimated weights below the 10th percentile, it's really when you get down below the 5th percentile that the risk really starts to become significant. And like a lot of things in medicine, we kind of build in a little buffer zone of safety before we get to the real problem. And this is true of fetal growth restriction. Next slide. So how small is too small? Let's just talk for a moment about defining growth restriction. Next slide. So for birth weights, we use less than 10th percentile to define growth restriction. So this has been carried over to the prenatal life of the fetus. And about 2 years ago, the Society of Maternal Fetal Medicine, along with ACOG and AIUM, updated the definition for growth restriction to include both an abdominal circumference and or a fetal weight less than the 10th percentile. This is similar to birth weight definitions. We've further adopted some of these using very small gestational ages being less than the 3rd percentile, and again, small being less than the 10th percentile. Next slide. Now, what about fundal heights? Are these of any value? We do these at each prenatal visit beyond 20 weeks. And there actually is a very good sort of consistent relationship between the gestational age and the fundal height measurement in centimeters between 20 and 32 weeks. But beyond 32 weeks, fundal height measurements are notoriously unreliable due to this condition known as lightening, which is essentially just the dropping of the fetus into the maternal pelvis. So if the baby drops, the fundal height drops. So beyond 32 weeks, they're often inaccurate, but prior to that time, they can be helpful. And it's recommended that a lag of 4 centimeters or more be used to indicate a suspicion of fetal growth problems. This only has a sensitivity of 27% for detecting growth restriction, and it has a positive predictive value of 18%. That means out of 100 predicted small babies, only 18 are actually going to be found to be small. So it's not terribly predictive. In fact, risk factors are for growth restriction are more predictive than fundal heights. But some people would say, the price is right. It's essentially free, and it may actually help identify a few cases. So it's probably worth doing. Now here's just a list of various etiologies or causes of a baby growing more slowly than expected. And you can see they're sort of equally divided between fetal, placental, and maternal causes. So we're going to sort of help reduce the number of etiologies that we're going to talk about today. Next slide. Because when you have a complex situation like this, you need some sort of strategy to help you work through this long list. Next slide. And the strategy that's going to help us is dividing these cases into two groups based on sort of the body composition of the fetus. So on the left, you see a normally grown fetus, and then on the right, two abnormally small fetuses, and we subdivide them into symmetric or asymmetric based upon the relative sizes of the baby's head compared to the abdomen. So if their head and abdomen are similar size, it's called symmetric. If they have a larger head and a smaller abdomen, it's called asymmetric growth restriction. Next slide. And this is just sort of a graph that shows what these growth rates look like over time. So in the symmetric growth restriction case, you see on the right, both the head and the abdomen fall off the curve and become small as the gestation advances. On the left, with the asymmetric growth restriction, the head circumference is spared while the abdomen becomes smaller over time. So you get this asymmetric disproportion between head and abdomen. Next slide. This is just sort of a visual of what that actually looks like. We're all used to seeing these sort of normal fat plump babies on the right, and we're kind of shocked when we see how lean and what appears to be undernourished appearance of a growth restricted fetus on the left. Next slide. Now, why does this happen? What leads to this asymmetry? Well, we know from Doppler flow studies and microbead flow studies in animals that the fetus actually has three preferred organs that it is going to attempt to protect in situations of stress. And those three organs are the brain, the heart. Those two make sense to me. The third one surprised me when I was a resident and learned this, the adrenal glands, possibly because of the benefits of cortisol production on the fetus, fetal growth and fetal well-being. But those are like the three preferred organs. So how do you demonstrate preference for those three? You essentially redirect blood flow to those three organs, and the fetus has the ability to do this. It can increase blood flow to certain organs and decrease blood flow to others. And what's interesting is when you then go and look at how some of these fetuses do in the nursery after delivery, you see evidence that a lot of their complications are related to the organs that were deprived of blood flow. So for example, respiratory distress syndrome is the most common complication of prematurity and fetal growth restriction. So the babies have decreased blood flow to their lungs. They don't need lungs while they're in the womb, so they feel like they can sacrifice support to the lungs. Liver issues develop, kidney injury, and then things like neck or necrotizing enterocolitis due to a decrease of blood flow in the splanchnic arterial system, so not supporting the gut health. So most cases are mild, and these insults are minimal and short-lived, but in severe cases, they can result in incredibly complex and difficult neonatal complications. So then we can cross off a good number of these cases, and these are the ones that we're going to talk about in the next time. Causes of growth restriction due to things like genetic problems and infections. And we're going to focus really on a common entity. Next slide. And that is the placenta. So whether the cause is on the maternal side or the fetal side, the placenta is like the common denominator of these cases of asymmetric growth restriction. Next slide. Now, when I'm worried about the placenta, I kind of, in my mind, I go through three questions. How bad or how unhealthy is the placenta? Is that placental condition affecting the fetus? And if so, how much? Is the fetus actually getting sick from this situation? Next slide. And then one of our tools for answering those three questions is actually Doppler flow studies with the ultrasound. And just to remind you, the Doppler phenomenon is just that thing you experience when you hear a train coming down the train track. As it's approaching you, the pitch of the horn is increased, and then as it goes by, it's decreased. And what's helpful is that the degree of shift, so the higher the pitch, is proportional to the speed. So the faster the train's going, the more that pitch is going to go up. The same thing is true of ultrasound waves, and the same thing is true of light waves. If you're looking at quasars and things moving through the universe, this Doppler shift is very strongly associated with velocity. So we can use this to gain some information about how the fetus is doing. Next slide. So when I'm interested in learning about the placenta, I'm going to look at the umbilical artery and how blood is flowing to the placenta through the cord. When I want to look at how's the fetus responding to that, then I'm going to look at the middle cerebral artery. And then lastly, as an indicator of fetal well-being, we can look at the ductus spinosus. This is the fetal vessel that's very close to the fetal heart. And so it gives us information about the baby's cardiac function, essentially cardiac output. Next slide. Also, if we were just worried about placental function, there's a couple of other things we can look at besides Doppler. We can look at the amniotic fluid volume, because that's a rough indicator of how the placenta is functioning in terms of things like fluid transfer. So abnormalities of amniotic fluid volume can also raise suspicion about placental dysfunction. And then lastly, we can just look at the overall well-being of the fetus. So we can do a non-stress test or a biophysical profile or an oxytocin challenge test to just give us information about is the fetal well-being being compromised. Next slide. Yeah, oligohydramnios, especially when it's paired with things like fetal growth restriction, are really grim predictors of bad outcome. So just when we, so if you see decreased fluid, then you start thinking about other problems like fetal growth restriction and possibly even preeclampsia. These may even precede the findings in the fetus in some cases. But a normal fluid volume, which would be a pocket greater than 2 centimeters, very low incidence of the fetal growth restriction, less than that in the general population. Decreased to 1 to 2 centimeters, and there's a 20% incidence, and then less than 1, almost 40% or more. The oligohydramnios also can predict an increased risk of intrapartum fetal distress, so it kind of gets your mindset to think, yeah, you may be encountering problems trying to get the patient delivered. Next slide. So looking at the umbilical artery Doppler is going to give us information about placental perfusion. how easy or how difficult is it for the fetus to pump blood to the placenta and back? Next slide. This is the information we're going to get from the umbilical artery Doppler. So in these three slides, you see sort of a progression from at risk to in trouble. And essentially what's happening is the compliance of the placenta is decreasing. You see this decrease in diastolic blood flow. So you see at the end of each peak, that trough is getting deeper and deeper. And it finally hits the baseline, which is zero flow. So umbilical flow comes to a halt. And then in slide C, you see it actually reversing direction. So the placental pressure is so high, it's actually pushing blood back towards the fetus. So these are incredibly high risk conditions. Fortunately, not super common, but very high risk. So that's how you get information about the placenta. Next slide. So then if we want to start looking, well, how's the fetus responding to that? We can look at blood flow in the middle cerebral artery. And part of the reason is this is just an artery that's very easy to identify and measure. It also has this benefit that it's in the brain. So it's in one of those three preferred organs that the fetus wants to protect. So next slide. So on the left, you see a middle cerebral Doppler of a totally normal fetus. And then on the right, this is how they respond to placental insufficiency. They actually increase this diastolic flow to the brain that maintains normal brain perfusion and oxygenation in a time of stress. So when you see that, we call that a brain sparing effect. Next slide. And then lastly, if you ever get concerned about, is the baby getting into trouble or in a danger situation, then we'll look at the ductus venosus again because of its proximity to the heart. It's sort of like a central venous pressure reading that you would get on your adult patient in the ICU. Next slide. And here you just see a normal ductus venosus Doppler at the top, where you have positive flow throughout the cardiac cycle. In the bottom image, we're looking at the very bottom. This is umbilical venous flow, which is just forward and normal. And then we'll go to the next slide. And then this is what it looks like when the baby's getting into trouble. So you get, again, reversal of blood flow in the ductus venosus in a highly stressful situation. And those reversed flows are pushed into the umbilical vein in the form of these pulsations. So that's a very ominous sign when you see pulsations in the umbilical vein. Next slide. Now, is this information actually helpful at all? And the answer is it actually is. So fetuses who have normal fluid, normal umbilical Dopplers, and normal MCA Dopplers, there's a huge negative predictive value for that. So 97% or more of these fetuses, even though they're growth restricted, if all this is normal, they have excellent outcomes. So this Doppler information is actually very reassuring to us. Next slide. By contrast, if you see absent or reverse flow, like we demonstrated, 80% will be growth restricted. There's a perinatal mortality rate of 36%. That's just huge. When you look at the placentas of these pregnancies, over 70% of the arteries within the placenta have been obliterated. And this is why they're growth restricted, and this is why they get into trouble. If you identify something that severe, mean time to delivery is about a week. So once you've made that identification, you really know the clock is ticking and you don't have a lot of time to get ready for delivery. So you're likely going to put them in the hospital, give them antenatal steroids for fetal lung maturity. Sometimes we monitor them 24 hours a day. We're so concerned that the baby's going to get into trouble. And then it takes very little for us to justify delivery once we've identified Dopplers that are that abnormal. And we're often looking at that ductus venosus Doppler to help us time delivery. Next slide. So just the combination of this absent or reverse end-diastolic flow combined with pulsations in the umbilical vein, you can see the mortality rates there, just really, really concerning. And these venous atrial backflow waves are suggestive that the baby's becoming metabolically acidemic. That's been proven by umbilical blood sampling prior to delivery. Next slide. Sort of a side note, I talked about how we're concerned about both sides of the placenta, both the maternal and the fetal. So we can use Doppler to actually get information about the maternal side by looking at branches of the uterine artery. And these have been strongly associated with things like growth restriction, fetal demise, preeclampsia. And so what we're looking at here on the left is a normal uterine artery Doppler. And then on the right, they develop these very characteristic notching waveform patterns. This is the thing that's associated with preeclampsia and growth restriction and stillbirth. Next slide. Is there anything that can be done to ameliorate or improve outcomes? There is some evidence that actually low-dose aspirin can help improve fetal growth in pregnancies that are at risk. So the more and more we learn about aspirin in pregnancy, the more it's becoming like the wonder drug. So it can help, in some cases, prevent growth restriction. It seems to reduce the incidence of preeclampsia by up to 60%. And then last fall, there was a publication out of Scandinavia that showed it actually could reduce recurrent preterm delivery. So now that progesterone is going away, I think we're going to be looking to low-dose aspirin for more and more indications. Next slide. So what do we do when we've identified asymmetric growth restriction? We start testing the fetus twice a week to make sure that they're staying metabolically normal. Once a week, we look at the fluid volume, again, because of that helpful information about placental function. We monitor their growth every 3 weeks. You might say, well, why are you waiting 3 weeks? That's a lot of time. And the reason is it takes almost 3 weeks of growth before you can interpret whether that growth is normal or abnormal. Growth scans less than that, you're struggling with just error of measurement. So that's why we wait 3 weeks. We're trying to get to 39 weeks because we know neonatal outcomes are the very best at 39 weeks. So when their estimated weight is between 3 and 10%, we shoot for 39 weeks. If they're in the bottom 3%, that extremely growth restricted category, then we often will deliver them at 37 weeks, just trying to prevent stillbirth. We're going to give them antenatal steroids if there's the potential for a preterm delivery. And then just as a clinical pearl, always be looking for signs and symptoms of preeclampsia, because there's definitely an association with preeclampsia and fetal growth restriction. Next slide. We always recommend kick counts, though I will say the medical literature has called into question just how predictive these are, but there's just such a strong association with maternal reporting decreased fetal movement in stillbirth that I think it's a reasonable thing to suggest all your patients do kick counts. Next slide. If you just focus on the middle line of this graph, you just see how this perinatal mortality rate is so strongly related to the gestational age. So this really underscores just the general idea that things that present early tend to be worse. And so growth restriction that shows up before 26 weeks, there's usually a bad reason why it's happening, and we're often limited in our ability to change outcomes. So gestational age is the strongest predictor of outcome for growth restricted fetuses. Next slide. What about long-term morbidity? The potential for normal long-term growth of these newborns is excellent. And again, it really gets back to how early did this start? How prolonged was it? And so fetuses, 50% that have a small head circumference will have a head circumference less than the 10th percentile at age of 8 years. Next slide. What about neurologic outcome? It really depends on the degree of the growth restriction, especially for a small head circumference. Again, the timing of the onset, gestational age at delivery, and how adequate was the postnatal care. Cerebral palsy is increased 4 to 6 times in growth restricted fetuses that present between 32 and 42 weeks. And then lastly, I'll just mention the Barker hypothesis, which was made by a British epidemiologist. He just noted that during this period of time in Wales, 1901 to 1910, where they discovered there were huge numbers of infant mortality. And then he looked at the growth restricted or low birth weight survivors and found out there was a strong association with coronary artery disease. So this has been shown in multiple studies that these growth restricted fetuses, if they survive, grow up to have increased problems in adult life with things like coronary artery disease, hypertension, stroke, etc. So what they call the thrifty phenotype seems to be a risk factor for these. They also found more abdominal obesity, adult onset diabetes, hyperlipidemia. It's unsure what the cause is. Some people think it's pancreatic or adrenal insufficiency or a sympathetic dysfunction, but just know that these survivors may have lifelong health problems as they grow up. And I believe that is it. So we can just pause and see if there are any questions.